you guys. This is going to be the first time I try to do this. Oh, there. Okay, it worked. I was able to go to the next slide. This is a module for urinary elimination. I'm going to try to do this in 10 minutes, 10 to 15 minutes. It's 11:23 right now. Okay, I'm going to be done by 11:40. So I just want to give you an overview when you're looking at slides, how you can pick the key points out, because in order for you guys to be successful throughout this nursing program, you guys need to be able to read information and pick the key points out. Since I didn't lecture in class on urinary bowel or nutrition, I'm going to go ahead and do this sort of way of doing it for you guys, and maybe this is something we'll integrate moving forward if you like it with other classes. We'll see. So here's the structure and function of the urinary system. Go ahead and take a look at that. You can always read the notes under, which will give you more information. But again, you just want to make sure you kind of remember that. Some of the things you want to take away from is that basically what the urinary system does is it removes waste, right? So it's urea is what it's removing. And the urinary system actually plays an integral part in the blood pressure, our blood pressures, and also our acid-base balance, right? Because it has to do with how we are, how our fluid levels are working. So your kidneys filter waste from the blood. They balance salts and electrolytes in the blood. They regulate blood volume and blood pressure and maintain acid-base balance. So those are the key points I want you to remember about kidneys. And kind of what you want to take away is if someone has kidney damage, what then might you see, right? If someone's kidneys aren't functioning, what might you see? You might see a change in electrolytes. You might see a change in their blood volume. You might see a change in the amount of urine they're making. You may see a change in their blood pressure. They may be acidotic or alkalitic, right? So that's really the key point I want you to start to put together. I don't want you just to memorize and be able to name what the kidneys do and the parts of the kidneys. That's sort of information that's sort of like on the back of your brain. You know, it's like, I always think it's like packing a bag, right? If you're packing a suitcase, that's like your underwear, right? You always have to have it. You always need to, right? You always want to have your underwear. You want to have clean underwear. You want to make sure you pack enough underwear. You don't ever want to lose those basic foundations. But now we're putting on workout pants and we're putting on a sweatshirt, and that's sort of the next layer of information. And so the next layer of information is taking what you know about kidneys and seeing as a nurse how you might see it present if someone's kidneys aren't working correctly. And so that's really the gist of what we're looking at. Urine is filtered in the nephrons, right? So if someone is having issues with their renal tubules, right, they're going to have issues with urine formation. So if someone is having some sort of damage, if there's something going on, we're going to see if there's decreased blood flow to the kidneys, it's not going to be able to make urine. And that's really considered an emergency if that's happening. Filtration occurs in that it's hard to say, glomerulus, I think I said that right, and that's where urine is filtrated. So if someone is having a glomerular, I didn't say that correct, issue, that's where you're going to see electrolytes and things like that being off base. What are your ureters? You guys know what those are? Those go from the kidneys to your bladder, okay? So if urine is retained in the kidney and it backflows towards the kidney from the bladder, you're going to get kidney infections, right? So if you have some sort of blockage in the ureter, if you have something that's not letting the urine get from the kidneys to the bladder and then out your urethra, into the toilet, hopefully, if it's backing up in the ureters, you're going to have infection. You're going to have kidneys infection. So if you have inflammation, that's why sexually transmitted diseases can actually cause all sorts of inflammation and stuff and actually cause kidney issues too. You guys know about your bladder and urethra, right? You need a sphincter for continence control. And we'll talk about that as we move on. So someone has diabetes mellitus and they are worried about kidney disease and they want to know, where does urine form in the kidney? Well, it doesn't form in the bladder, right? We know that's the depository before it exits the body. The B is silly because what kidney forms in the kidney, it doesn't make sense. And ureter is just a tube to get the urine from the kidney to the bladder. So it's the nephron, that's the part. So if someone has nephritis or something going on, it's going to affect urine. Innervation, what does that mean? When we talk about innervation of the bladder, that's the nerves. So the bladder has a ton of different nerve innervation, that causes us to feel when our bladder's full, to feel when it's empty, to feel that urge to pee. So anything that can affect nerves can affect urination, right? So think about all of the different things. Micturition is another word for urination. So know that word, because like we found in tests, sometimes you see a word and you don't know what they're talking about. Micturition. I think I'm saying that right. Micturition. So anything that affects nerves is going to affect possible urination, right? So that's why those in clinical, a lot of what we're dealing with is incontinence. And there's possibly where the bladder's just emptying, right? But the biggest thing we're worried about is if someone doesn't feel an urge or urgency and the bladder just becomes distended and distended and distended, and nothing in the brain can signal those sphincter muscles to relax and let the urine out. That's an emergency. We cannot let someone's bladder just get more distended and more distended. And so that's why we see people on spinal cord with spinal cord injuries who no longer have that sensation. Usually it's not that the bladder is just relaxed and will keep emptying. Instead, it holds it, and those patients have to be on some sort of protocol where they're cathed every certain number of hours, etc. Normal urine is sterile. Isn't that interesting? I always find that super interesting. It's sterile. The bowel is not, but your bladder is. Bladder is sterile. So it can be diluted, it can be concentrated, it has to depend on what you, as we all know, what you eat. If you eat asparagus, you can smell. Some people, actually, it's a genetic thing. Not everyone has that, but it's how your body metabolizes one of the, I don't know what the right word is, nutrients or whatever in asparagus, that not all people's pee is affected. Just FYI there. So basically, the average adult, I like to say 1 to 2 liters. That seems a little easier to remember than 960 to 1920, but 1 to 2 liters of urine a day. But we all know from ourselves, how that can be affected by exercise, heat, are we sweating, what have we had to drink, how much salt did we drink, all those kinds of things. So it's important that someone is peeing appropriately. The amount that someone's urinating, their patterns of how they urine, is all how they urinate are all signs of, can be signs of something else going on, whether it's with the bladder, whether it's with the kidneys, right? So normal urine is sterile, so you should not have bacteria in the urine. That would be a urinary tract infection when you have that. So we have all different kinds of things that alter our elimination, right? You can either have it retention, I talked about that, where it doesn't empty, or you have loss of voluntary control. So that's someone who's incontinent. We see a lot of that with our elderly patients, and some of it is cognition. They just no longer recognize the urge. All different kinds of things. So sometimes with a urinary tract infection, because of the inflammation, everything gets a little bit messed up and you constantly feel like you have to pee, but then when you go, it's just a drop. So that sense of urgency is sort of affected by the inflammation. So all different things can alter the structure and function. Know all these words. We talked about these in class. I want you to know all those. Anuria is, understand, and I know I mentioned this in class, this is the failure of the kidneys to excrete urine, whether blood flow has been decreased to kidneys because of trauma, whether you have something else going on that has caused damage to the kidneys. This is a life-threatening condition. You have to figure out why. Why are the kidneys no longer making urine? And if that's going to continue, this patient's going to need to be on, dialysis, and all sorts of things are going to need to be figured out. Just know what dialysis is, okay? Basically, it's during hemodialysis, the blood goes, through a machine that basically cleans out the blood because the kidneys aren't working. So dialysis is a way to bypass kidneys that aren't working. So if your kidneys aren't working, you will have to go on dialysis to filter your blood, because we know we need to filter the anuria out of the blood, right? So or the urea, we know we need to filter the urea out of the blood. So just know what dialysis is, okay? Here's a picture of someone going to dialysis. From a nursing standpoint, what kinds of things do you think it would affect? It affects psychologically. It affects people they can't work often because they have to be on a schedule for when they have dialysis. Hopefully they can get a kidney transplant, but some aren't able to. I mean, it is a huge, huge lifestyle change. Oliguria is where you just have less, right? So we say less than 400 cc's a day in adults. And you can have it from all different kinds of things, right? So, and we look at that, when someone's in acute or chronic renal failure, and the kidneys aren't working as well, we'll start to see it. This is different than anuria, where no urine is being made, right? And no urine is being made does not mean it's being retained. Urinary retention is different. That's the inability for the bladder to empty. This is the kidneys aren't able to filter and make urine. Therefore, we have to filter the blood ourselves, because urine is how we get rid of those products that need to come out of our body. So just know what oliguria is. I&Os is something you will do a lot as a nurse. It can give us a lot of information, especially someone who has any kind of acute or chronic renal failure. We often are even on like a strict fluid intake of how much they can take, and usually it's less, because doesn't that make sense? If you're in renal failure and your kidneys aren't working that well, we need to probably restrict the amount of fluids that you have. And that's something the doctor is going to figure out the amount. Polyuria is you're making too much. Why are you making so much urine? We see polyuria in a lot of people who are diabetic, especially if they're undiagnosed. Sometimes it's the first sign of someone being diabetic. Why? Because you have all this extra sugar. What do we know? What would happen if you have all this circulating extra sugar? You're going to, in cells, you're going to pull water into the cells to try to dilute it, right? Because we always are trying to get to this status of equilibrium. So we have all this extra circulating sugar. We're going to pull all this fluid to try to dilute the sugar, and then it's going to go through your body, and you're going to keep peeing and peeing and peeing and peeing and peeing. Okay. Also, if you drink a lot, you're going to find that. I'm going to look in the notes and see, did I get through this? Nocturia, someone sleeping, going to the bathroom during the night from a urinary tract infection. We see this a lot of times in our elderly population. This is a big deal. They just are lacking the cognitive ability to be woken up by those sensations, because everything is just getting a little dampened down as they get older. All right, I have 5 more minutes. I'm getting there. Dysuria, painful. Hematuria is red blood cells. And sometimes you won't see it. If it's gross, meaning when they say gross blood, it always means like, I know that sort of sounds bad. They don't mean gross like ew. They mean gross like you can see it. Like something is gross, it's visible. Gross blood is blood that you can actually see with your eyes, versus microscopic hematuria, which is blood you can't see, but the red blood cells are picked up on a exam. It can mean all different kinds of things, often signs of a UTI. Incontinence, just go through all different kinds of incontinence. People who have weak bladder muscles, sometimes after you've had a baby, they have stress incontinence, which means they pee their pants if they sneeze, right? These are all types of urinary incontinence. Urge incontinence happens a lot in the elderly, where all of a sudden they have such a strong urge to go, and then their bladder rapidly contracts. And so we do a lot of medications to stop that urge incontinence. That's a lot of times what you see in the elderly, is all of a sudden they have to go and they can't get to the bathroom in time. Sometimes you'll have a mix of both, right? Everything isn't always black and white. Functional incontinence, whatever, everything seems to be functioning effectively, but they're still incontinent. And then overflow is they cannot empty their bladder. There's some sort of muscle or nerve, something going on, and there's this constant dribbling. So urinary retention is a big deal. We need to find out why someone's having urinary retention. Acute urinary retention might be from surgery. You've had surgery and you have anesthesia and you don't feel your bladder. You've had an epidural, so you're not able to empty your bladder. So anyone who's had an epidural has to have their bladder definitely, has to have their bladder, my battery's running low, so I have to get up while I'm talking. We have to, make sure their bladder isn't getting over distended. In clinical, you guys were able to look at what did we look at? What was that called? The bladder scanner. And that was kind of cool, is to be able to do the bladder scanner and see, and that's used to see, can someone be emptying their bladder completely? Because a lot of times, someone who has some sort of spinal cord injury might be able to enter their bladder a little bit, but not completely. So those are all different types of urinary retention. I'll let you read that. All different kinds of things affect that. You guys can read through the diversity considerations. Certainly, I've touched on developmental and psychosocial factors of all this. You guys can do that quiz yourself. We've talked about this. We've talked about this. Again, just skim, don't need to memorize. If it's highlighted, I pay closer attention to it. So UTIs, right? The single most common hospital-acquired infection. That's when they talk about those CAUTIs, catheter, oh, what is that? Catheter something urinary tract infection, catheter acquired. Sorry, that's what a CAUTI is. And hospitals have to keep track of their CAUTI rates. It's a really big deal. And we know why there's tons of protocols and procedures now into how you catheterize someone, and they have to meet certain criteria now to be catheterized, all sorts of kinds of things. So you don't need to worry about a urinary diversion. I mean, that's not something that we're really going to see. Just know it occurs. You can read through health assessment questions and things you might ask a patient. Just skim through those. There's a picture of a bladder scanner. Again, these are things we look at when we look at urine, okay? These are things that we can just see on, with our eyes. Again, other things that are looked at. Pay attention to this. One of the things we look at is your BUN and creatinine. And we look at how they react to each other. And so in an acute kidney failure, we're going to see a rise in the BUN to creatinine ratio. And someone's going through shock, dehydration, severe bleeding, right? If blood is being shunted away from the kidneys and it's slowly starting to fail. Anything that stops blood going to the kidneys. So just sort of read through that. On a UTI, these are things that we look at. It's not normal to, on a urinalysis, it's not normal to see protein. We shouldn't see glucose. You shouldn't see ketones. So it's just things that they look at to try to rule out other conditions. Know that nitrite levels can be a sign when bacteria is present. So if a patient is positive for nitrates, it's often assumed that they have a UTI, and then we send a culture and sensitivity. Why do we do that? Because we've learned we need to know what kind of bacteria is growing and what kind of meds will kill it. We don't want to just, we don't want to do these broad spectrum antibiotics. Sometimes we actually will collect for a whole 24 hours to give us how much urine is in 24 hours instead of just a one-time thing. So again, you can just read through this. They use ultrasound, they use x-rays. They'll do an IVP where they actually use some sort of contrast to go in, or a CT. These are all different ways we can look at the bladder. Cystoscopy, similar to colonoscopy, what we talked about. This is a scope is actually inserted into the urethra to look at visualization of the bladder, and then they can do a biopsy. So it's the same idea, and they can actually see the lining of the bladder. So this would be often if they're concerned about, bladder cancer, those kinds of things. I'm going to let you just read all of this. You guys know that. Skim it, skim it, skim it. We've talked about this in class when we did our whole project that day. Kind of a takeaway is that females are at increased risk for UTIs. Therefore, it's really important we teach people to wipe from front to back. And when we use a catheter in a patient, we want it to be a closed system. And really, they used to irrigate bladders, and now they've really found it's not okay. They really don't want you to do that, because anytime you introduce anything into a catheter, you risk the effect of pushing bacteria up into the bladder, which then it can travel to the ureters and to the kidneys. So just kind of things that have changed. So you can read, you'll understand this. If you have a home health alert, different kinds of bedpans and urinals. You guys are getting practice on seeing these in the hospital. Why we use some of these, obviously, if someone's at risk for fall, they can't get out of bed, all those kinds of things. Bedside commode can often be used if someone doesn't want to walk all the way to the bathroom. Usually we put them on a schedule and kind of encourage them to void, at certain intervals, I's and O's. We call it a hat, right? So we put that hat in the toilet and someone pees in it and we can see the amount that they peed. And this just kind of gives you an idea of how you do I's and O's. I think we've done this. They like to ask developmental questions and how it may affect kids. So keep in mind, sometimes kids, while all of these things are true, the kind of most important thing is that without their parents, sometimes kids would be scared. Read about Kegels. Kegels are exercises you can do to train the PC muscles, it's called. Those are the muscles of the pelvic floor that surround your urethra. And so a lot of times people will go to physical therapy, or doctors will teach patients how to do these pelvic floor exercises if their bladder, especially if they're having like leaking of urine where they can't hold it, like that stress incontinence. This is what's used to help treat stress incontinence. Again, ways to prevent UTIs, encouraging women to urinate after, actually everyone should urinate after sex. It's women's urethras are a lot shorter, so they are at increased risk for UTIs, but men as well. So everyone should, drink lots of water, because the more you can move fluid through your body, the less it can just sit there. All of those kinds of things. So this is about those CAUTIs, that really catheterization causes 80% of UTIs. So you guys, I know, I hope you can see my arrow while I do that, but these are the different types of Foley catheters. This is what we call a red rubber, and all you do is, it's just a straight catheter. You go in, it drains the bladder, you pull it out, just straight catheter. Foley triple lumen, this is what you see if you have to do some sort of bladder irrigation. So this is what you do to blow up the bubble. This is where the urine comes out of. And then this port can be used if you're irrigating. Remember I said that's a triple lumen. We don't like to do that very often, but after like prostate surgery and things, they get blood clots, so they need to be able to irrigate it. This is what you're normally going to see. This is just your normal Foley catheter. There's two parts. Urine comes out of here. This is where you attach a syringe to blow up the balloon to keep it in the bladder. It's a closed system. We try to keep it all closed to, keep bacteria away. This is a coude. This would be used for someone. I'm just going to actually say exactly how they say it. This is like someone who has scar tissue and things like that, where it may be difficult to get through. It's more a hardened tip, and that's called a coude catheter. So you have a straight, this is just one time in, one time out. You have a Foley, and it has a port to blow up so it can stay in the bladder. You have a triple lumen, and this is used for so that you can irrigate the bladder. And you have the coude that has a little bit of a firmer tip that's going to be used for someone who has like scar tissues or they have a hard time getting up. Well, I'm going over more time, but this goes into it in more detail. Again, I think you guys can read all of this. You can read what a UAP can do. In some instances, a UAB can straight cath. But all of those things, they always have to be able to show that they know sterile technique and all of those kinds of things. I just want you to read that. It's interesting, and I want you to read about that. I think it's very interesting. This is where they talk about why we shouldn't irrigate bladders unless needed. And these are all evidence-based practice to help prevent those CAUTIs. Again, collaboration and delegation, just read through, you don't need to take notes on this. Just read through. Know that, like we keep talking about, all these organizations set the standard and protocols based on evidence-based practice. So the CDC is the one who sent all of these kind of protocols that we need to follow to prevent CAUTIs. And also, we know that hospitals have to report their rate of CAUTI infections, and it can affect reimbursement. So you can use just soap and water on the urinary meatus if someone has a catheter in place. And so basically you can look at that. This is a big deal. Catheter bags have to be kept below the level of the bladder. Why? If you raise it, you're refluxing urine back into the bladder, right? And what if there is a little bacteria that somehow got up into the tube, and hopefully the urine's just going to push it out. But if you pull it up, it's going to flow back into the bladder. It could go into the ureters, go into the kidney. So we always want to keep and educate patients to keep the catheter bags below the level of the bladder. And that's something that you're going to want to know, because you might see that in a test. This is a catheter that's actually inserted directly into the bladder above the pubic bone. You don't need to know too much about that. Condom catheter, I think you can figure it out. That's pretty evident. Perineal care, again, it's really important, especially if someone is having incontinence or if they have an indwelling catheter, that you're really just using soap and water. All of those other kinds of things that you can use cause inflammation and infection. So again, you can just read through this. Nothing that you need to know by heart. I think it will make sense to you. Looking at evaluation and why we do this, right? So your takeaway is, if someone has kidney disease, what are the types of things you're looking at? All types of stuff. So I think this makes sense to you. Good. I'm only 2 minutes over. I hope this was helpful. And so now I need to figure out how to turn this off. So bear with me for just a minute. You all are smart and brilliant, and I know that you all are going to do well. I'm sorry, now it's losing the, What happened here?